Committee will come to order, and the chair recognizes Mr. Space.
Madam Chair, if I could, I don't expect to exceed the 5 minutes, but I did not do an opening statement today. If I could be permitted the luxury of 8 minutes.
Yes, this is clerical error.
No, thank you, Madam Chair. Thank you, Mr. Collins, for joining us today and for offering your testimony and for the work you do at NIH. I personally think it's an underappreciated agency that we should be devoting more resources and assets toward. I wanted to focus my questions today, however, on one specific disease, and that's diabetes. As you probably know, the ADA recently conducted a comprehensive study in which it was determined that, these are 2007 numbers, by the way, which undoubtedly are significantly lower than they would be today, but that determined that we're spending as a nation about $174 billion every year. Most of that money represents costs associated with health care for those suffering from diabetes, and particularly those in the chronic stages. But a significant portion also represents lost productivity. And this is one disease. In 1 year, we spend more as a nation than we did, for example, in just about any year during the war in Iraq. Obviously, if we were to be able to cure this disease, we would mitigate and, in fact, eliminate the expenditure of trillions of dollars over the next 50 years in terms of the long picture. I happen to have a son who suffers from type 1 diabetes. He's 19 now. His name is Nick, and he was diagnosed when he was 6 years of age. And after his diagnosis, my wife and I, we knew very little about diabetes at the time, but we began to educate ourselves on this devastating disease. And this was in 1996. Here we are, 14 years later. In 1996, it was my impression that we were 10 years away from a cure. And this was based on exhaustive studies and research that I committed myself because of an obvious personal interest. And here we are 14 years later, and I'm still hearing the same thing. We may be 10 years away from a cure. And I'm familiar with the closed-loop system and the concept of an artificial pancreas that if every type 1 diabetic in the country had, it would eliminate countless episodes of suffering, premature death, and disability, but would also end up saving a lot of money in the long run. And my question is to you is regarding the special diabetes program. I understand that this has been funded at $150 million per year. Incidentally, sounds like a big number. It is a big number. But if we're spending $174 billion a year combating this disease, and we're to take 10% of that figure and spread it out over 5 years, say $17 billion, let's just round it downwards to $15 billion and spend $3 billion a year over 5 years. My opinion is we could give every type 1 diabetic in the United States a closed-loop system that worked and that was reliable and would more than pay for itself within a few short years. My question to you, Mr. Collins, is what is your assessment of the special diabetes program, its importance to researching and developing advanced methods of treatment, maintenance, and possible cure when it comes to type 1 diabetes?
So, Mr. Space, I appreciate your question, and especially the personal experience you've had with your son, Nick. And I think parents who have had that experience must be, like you, frustrated that we don't yet have a better solution to this clearly important and very serious disease of type 1 diabetes. The Special Diabetes Program, which, as you point out, is $150 million a year, it is set to expire at the end of fiscal year 11, and I know there are some anxieties amongst the investigators working in those projects about whether they are going to have to phase out their efforts at that point. It certainly includes a number of, I think, rather ambitious efforts, and certainly the artificial pancreas is one of those dreams that we all hope will come true in a broader sense in the not-too-distant future. But obviously, many challenges there in terms of how you get the engineering and the biology right so that you have a system that is reliable. Because obviously any system that has the capability of delivering insulin needs to be fail-safe, because overdoses would be potentially very serious. I think there's real progress being made there, but I'm sure from your perspective and from mine, it's slower than we wish it could be. In terms of type 1 diabetes and what causes it in the first place, we have, I think, a much better idea of what the genetic factors are. We now have accounted for more than half of the heritability of type 1 diabetes. And there's this program called TEDDY, which is now following several thousand children who are at high genetic risk to see whether, in fact, they begin to show some signs of the autoimmune component, which is the sign that the disease is getting started. Because as you probably know, by the time a young person shows up with actual symptoms of diabetes, most of those beta cells in their pancreas have already been destroyed by the autoimmune process. And the best hope is to catch that early and then treat it with appropriate drug therapies, including a new therapy called rituximab. So I would say there's reason to be optimistic that the steps are moving forward, but I hear what you're saying, that you heard that in 1996. I'm impatient too. I want to see this disease conquered. I want to see the best ideas supported to make that come true. It is challenging to figure out for us exactly how to take the resources we've got and apply them in the best way. We do what we can in terms of estimating what's going to work and what's not going to work. There's steps forward. Sometimes there's setbacks, especially in clinical research, where you know you have to come up with something that is both effective and safe. But I think with the way that the field is moving, it's hard for me to see that that dream you were promised in 1996 is not going to happen. It's just very hard to put timetables on these kinds of trajectories. I wish I could.
Apart from the obvious benefits associated with the alleviation of human suffering in saving lives, is it your assessment that that would also save a lot of money? A
lot of money, absolutely. And I certainly hear what you're saying about both for type 1 and for type 2 diabetes.
Sure.
The huge sums of money that in our medical care system are going to take care of individuals. We also have very vigorous research programs on type 2 diabetes, particularly now in prevention, where we have the ability perhaps for people who are starting to tip over into that to be able to prevent the full onset of the disease, following up on the results of the diabetes prevention program, which has taught us how to do that with simple things like diet and exercise and lifestyle changes that can be successful if properly managed and coached.
And just finally, in the event that the special diabetes program were not to be reauthorized, would that have a deleterious or negative effect on advances in the field?
It certainly would. I mean, with all the momentum that's been generated because of that special program, the idea that those dollars would sort of come to a halt would force the NIDDK, the Diabetes Institute, to make some very difficult decisions about what they could continue and what they could not.
Thank you very much, Mr. Collins.
Mr. Space, just the chair will announce that that we've asked for the Diabetes Caucus has asked for a full hearing on NIH efforts towards diabetes research and prevention, and so we'll look forward to that hopefully later this year.
I look forward to that as well, Madam Chairman.
I'll recognize gentlelady from Wisconsin, Ms. Baldwin.
Thank you, Madam Chair. I have ambitious plans with my 5 minutes of questions, but we'll see how far I get into this. First, I wanted to just make a comment. I was present when Dr. Christensen was talking and asking questions and bringing all of our attention to the issue of health disparities in minority populations. And I just wanted to share with you my interest in expanding the way we think of that to include also the lesbian, gay, bisexual, and transgender population. In years past, when we've had your predecessor in front of the subcommittee or other agency heads, I've asked about the state of knowledge on LGBT health and what sort of data collection we have, what sort of information. And I'm sad to say that the answer was, either we'll get back to you or we're not aware of any, even asking questions related to sexual orientation or gender identity to be able to gather the evidence and the data. I don't know what role you might have personally played in the focus that the IOM is now putting on this question, but I'm delighted and want to commend any role that you did play in bringing that together, because I think it will examine the current state of knowledge and hopefully produce recommendations of where we can obtain even greater knowledge. So that's just a comment. Really, with the rest of my time, I wanted to get as much of a status update on some new programs, et cetera. If you don't have the information available today, please feel free to respond at a later point. But last year, the Christopher and Dana Reeve Paralysis Act was signed into law. I had authored the freestanding bill before it was included in the public lands bill. And this authorized NIH to undertake 2 grant-making processes. One would fund grants for consortia in paralysis research. The other would grant funds to maintain a clinical trial network with sites focusing on people living with paralysis. I'm wondering if you can give me any update on the implementation of this rather new legislation.
Yeah, happy to. Very quickly, in terms of LGBT, we are in fact supporting, and we've done an inventory here, some 272 projects through NIH research costing over $239 million. So there is a research portfolio there, but we are very much looking forward to the results of this IOM study, which I strongly support, to try to learn more about the needs and the research opportunities that NIH should be addressing. In terms of the Christopher and Dana Reeve Paralysis Act, yes, there certainly has been, as a consequence of that, the formation of a network here, which is funded by the National Center for Medical Rehabilitation Research, which is within the Child Health Institute. Traditionally, that's where rehabilitation research has been located. But together with the Neurology Institute and the National Institute for Bioimaging and Biotechnology, that resulted in solicitation of a whole bunch of interesting proposals, and in fact 7 sites that received the best peer review recommendations are now being funded by those 3 institutes. And they're going to look at biological, medical, behavioral, social aspects of paralysis and very much try to make this a consortium effort as opposed to a collection of disconnected research projects.
Great, thank you. Recovery and Reinvestment Act funds were awarded through the National Center for Research Resources to address the critical research infrastructure needs across the nation. But I would say that the funds were inadequate to meet all the critical needs that are out there. And so I'm wondering, moving forward, assuming, or once the recovery dollars are expended, will funds for construction or remodeling of facilities be a priority and be allocated to NCRR?
So yes, we were delighted in the Recovery Act to have $1 billion to put forward for construction and renovation, and those grants were rigorously reviewed, and fairly recently decisions made and announcements put forward, and those $1 billion are going to support grants and new construction in 146 projects in 44 states and the District of Columbia. So this was clearly one of those occasions where dollars from the Recovery Act were going to support both medical institutions and the economy in terms of the reconstruction efforts. Future funding is not included in the President's budget for FY11, and I must tell you that when budgets are tight, as we fear they may be in FY11 and beyond, dollars for this kind of application is often hard to come by, and that's something the Congress decides. We don't decide. If we don't have an allocation in that part of our budget, we're not allowed to spend the money on buildings and facilities, so we wait to see what the appropriators tell us.
Okay. I see I've run out of time, so I will conclude. Thank you.
Thank you.
Yeah, if the gentlelady has a couple more questions, we had said we would be willing to do a second round, so you can.
Oh, well, I would be delighted to use just a couple more minutes, and then I won't need a second round. The University of Wisconsin has long been responsible for running the National Stem Cell Bank. This year, we've been informed that NIH would like to take this process through a competitive rebid. And I wonder if you could tell me a little bit about what the timeline and the selection criteria will be for the rebidding of the National Stem Cell Bank.
So the University of Wisconsin has been such an important leader in this whole field. I think I mentioned earlier the contributions of Jamie Thompson and the way in which the Wisconsin effort led to the formation of this bank was certainly an important resource for individuals who would want to get access to these stem cell lines and knew that they had been properly maintained and they could count on their quality. Now that there are, as I mentioned earlier in this hearing, 73 such lines that have been approved and going up, we are going into the hundreds before long, there is a big question mark in many people's minds about exactly what's the right way to make sure the lines are accessible to investigators who want to use them. Some will probably be used more than others. There will be some favorites, no doubt, as has been the case in the past. What we are trying to ascertain is whether it is actually time for this kind of banking activity to move into a competitive private sector enterprise, because certainly in other circumstances where there are biological resources that many individuals are interested in, the time sometimes arrives where it is more efficient and more cost effective to have this conducted by a small company who would then be basically recovering their costs of distribution by a modest charge. What we don't want to do, however, is to have that end up resulting in excessive costs for NIH investigators. That would sort of defeat the purpose. So we are still exploring what the right pathway might be, but it seems likely that we will want to set up a circumstance where there's more than one bank, because obviously you wouldn't want to have the entire field resting upon a single resource. And it will be, I think, a few more months before we have a clear sense of what's the best strategy for making sure that we have cell lines that are maintained at high quality and made available to investigators at reasonable cost.
I have two more, but two more topics. In the fiscal year 2010 appropriations bill, Congress called on the Office of the Director to engage in specific efforts to improve research on women's pain, including coordination of a Trans Institute research initiative in fiscal year 2010 that will support studies aimed at identifying common etiological pathways and with the goal of identifying potential therapeutic targets. And secondly, a conference to be held along the same lines. Could you tell me about the status of your efforts in this area?
So we certainly read that part of the healthcare reform bill carefully, and we're happy to be called upon to work in this area of pain, which we agree is extremely important. There is a pain consortium at NIH, which has been in place for several years, which involves quite a number of the institutes that have an investment and an interest in this area. And this is another sort of encouragement for that effort to get even more involved. We are, in fact, planning the conference that is being asked for, which I think is to be hosted by the Secretary in the not-too-distant future, because I think there was a timeline on that. And there is also an exhortation in the Affordable Care Act bill about coming up with some new common fund ideas for pain research, which is certainly something that is being looked at by the Pain Consortium to see if there are opportunities there. In addition, there have been a number of specific workshops focused on particular subsets of pain to try to bring investigators together with new ideas. And I must say, there are some exciting things coming along. I just mention one, which is another example of how a rare disease can really lead you to a very interesting new hypothesis. There are rare individuals who are born with what's called congenital insensitivity to pain. A particularly dramatic publication a year or so ago studying a Pakistani family where the number of the siblings were completely unable to feel pain, which is not actually good for you.
Right.
These siblings ended up involved in street theater where they would walk on hot coals or they would actually pass knives through their arms. Obviously, amazing people going by, not feeling pain, but of course putting themselves in great jeopardy. The cause for that has been discovered, and they are basically missing one of these sodium channels that normally transmits the pain signal in the nervous system, and they're otherwise entirely well. Now that's a really interesting finding. That says if you could identify a drug, a small molecule, that blocked that activity in the rest of us transiently, that would be an incredibly powerful pain reliever, an analgesic. And many companies have now jumped on that description of a very rare family, thinking this might be the best clue we've had in a long time for a totally new approach to pain management.
Very interesting. My last question, and you've been very tolerant of my battery of different updates. I'm curious about the National Research Service Award funding program. Are there any efforts underway to reframe that, change the amount or the allocation of training funds under that program?
So we are aware that stipends for NRSA trainees, the Ruth Kirstein NRSA awards, have fallen behind over the course of many years without having a substantive increase in quite a long time. And so we have supported a 6% increase in the current circumstance to try to make up some part of that. And there has been a sense of the Congress, and we agree with this, that we should continue to try to catch up a bit here. We depend on these trainees to do a lot of the frontline research. It's part of their training, but they're also really important for the productivity of the enterprise. We certainly wouldn't want talented minds to go elsewhere because they just couldn't figure out how they're going to buy the groceries. So we are doing what we can to try to catch up on that, recognizing that we have fallen behind. It, of course, comes at a tough time if we're seeing a more stringent budget looming in the future. If we are going to increase stipends, we may have to decrease the number of trainees because there's got to be an ultimate reckoning, and we would hate to do that too. So it's just one more example of the tough decisions that may be facing us at a time where the economy is struggling.
Gentleman from New York, Mr. Engels, recognized.
Thank you, Madam Chair. Doctor, before I came here, I was at my other subcommittee on the Energy and Commerce Committee, which is the Energy Subcommittee, and we were questioning the BP executives and some of the other executives, and I can tell you this subcommittee is much more friendly today.
I'm glad I'm at this table and not in that other room.
I want to, first of all, personally thank you for the good work that you do. I followed your work, and I'm very impressed. You spoke at the New Dems several weeks ago. I was there, and very, very impressed with what you have to say. So thank you, first of all, for all the good work that you do. At that meeting with the New Dems, you'd mentioned a drug called, I think it was Iressa?
Yes.
About breast cancer.
Mm-hmm.
I'm wondering if you could just, again, tell us about that, and if somebody would want to sign up for it or anything like that. Is that possible?
There are certainly trials going on. So Iressa, for which the generic name is gefitinib, is one of these new targeted therapies for cancer about which there is a great deal of excitement. So Iressa basically works by blocking the action of a particular kinase, which is an enzyme that is normally present in cells, but in cancer cells from some tumors gets overly activated by a mutation. And if you are somebody who has a cancer that has that specific mutation, Iressa can be extremely effective. I think I told the story of a woman whose cancer was diagnosed. She had lung cancer, which was already metastatic to her brain, in 2002 and expected to live for a few months. She's doing fine today, I'm happy to tell you, because this drug was the perfect antidote to her particular tumor mutation. Now, that's the good news. The troubling part of this is that Iressa doesn't work for about 85% of people with lung cancer because they don't have that mutation. They have some other way that their cells have gone haywire and are causing the cancer in their system. But it does say that we are reaching the point with Iressa, with the drug I talked about in my opening statement, which is another example of this sort of targeted therapy for cancer, where you can sample a tumor and say, okay, what's here? And then look at your list of drugs that are available and do the match. And as that match gets more and more possible, because the list of drugs and the list of targets gets longer, we're going to see a real transformation in the way that cancer is approached. And that's a great thing. But it's personalized therapy we're talking about now instead of giving everybody the same dose of chemotherapy.
Thank you. I'd like to ask you a question on gestational diabetes. According to the American Diabetes Association, gestational diabetes affects 2 to 5% of all pregnant women, and that's 135,000 cases every year in the United States. And it occurs, I'm told, in pregnant women who've never had diabetes before but develop it between the 24th and 28th weeks of pregnancy. And while it generally goes away after pregnancy, it can have health impacts for both the mother and the baby. I'm told that there's currently an insufficient system for monitoring cases of gestational diabetes to uncover trends and target at-risk populations. And for that reason, I and Dr. Burgess have introduced the Gestational Diabetes Act of 2010. And I'm wondering if you could discuss some of the research currently underway to address the need for comprehensive information on the causes and best treatment of gestational diabetes.
It's a very important problem and one that we need to address both in terms of research and in terms of just the public health and trying to identify individuals who have risks of this sort. Gestational diabetes is, in fact, a risk to the pregnancy as well. It is associated with higher birth weight, with prematurity, and certainly something that you want to try to control because the mother who has out-of-control gestational diabetes is also likely to end up with preeclampsia. But more than that, if you get the mother through this experience, and most do, the risks that that woman will go on to full-blown diabetes are substantially increased. And ultimately, about half of women who have gestational diabetes will ultimately become diabetic. So it is apparently one of those circumstances where pregnancy is kind of a stress on the system, and somebody who may already be predisposed, it becomes more clear in the course of a pregnancy that that's the case. So we need both better methods to monitor during pregnancy, which means our medical care system needs to be, of course, accessible to those who need those services. It is not particularly difficult to assess this if that person's getting adequate prenatal care. And we need, of course, methods to prevent it in the first place. And it appears at the present time that the risk factors for gestational diabetes are pretty much the same as the risk factors for type 2 diabetes in general, which is to say family history, which is to say body mass index, obesity, and exercise. And what we've learned in terms of how to take people who are predisposed to diabetes and prevent that from things like the Diabetes Prevention Program are probably very applicable here as well. But certainly women who have gone through this experience and had gestational diabetes ought to have a particularly good opportunity to recognize the risks to their future health and to be given the same kinds of interventions that we now offer to people with pre-diabetes to try to reduce the risk of coming down with the disease. So there's a lot we can do there, but I agree that has not been fully realized.
I'd like to ask you about Charcot-Marie tooth disease. There is an innovative partnership between the NIH's National Chemical Genomics Center and the Charcot-Marie Tooth Association. I've worked with that association, and I think that this could serve as a model of future rare disease research and drug development. So I'm wondering if you could describe the program and offer your thoughts on it.
I appreciate the question because I do agree this is a very exciting program. My father-in-law has Charcot-Marie tooth disease, so this is a disorder that's not only something from my clinic but also from my family experience. And this is an interesting disorder which causes a weakness of the legs particularly, but also the hands over the course of time, and can be quite debilitating. But it is well understood now what the cause of that is. The genetic abnormality has been now laid out in great clarity. But what could you do about it? So working with the NIH Chemical Genomics Center, which is this remarkable facility that has been mentioned already at least once in this hearing, an effort is being made to identify a small molecule, which is sort of a drug, that would basically compensate for the genetic problem that's found in individuals with this type of Charcot-Marie tooth disease, so-called CMT1A. And that is an early stage effort, but it's a good example of this therapeutics for rare and neglected diseases effort that NIH is putting increasing effort into. Charcot-Marie tooth is too rare for companies to generally see this as a good investment for them in terms of developing a therapeutic. But with the Chemical Genomics Center working with academic investigators who know a lot about the disease, if they can push this forward to the point of identifying a promising compound, then you could imagine a company be getting pretty interested in licensing that out and carrying it all the way through to a clinical trial.
Thank you. With the Chair's indulgence, I'd like to ask you about mental health problems of children and adolescents. Because in my district, we have the Nathan Klein Institute, and it's an internationally known psychiatric research facility, and they believe that the unmet mental health problems of children and adolescents is one of the most important continuing problems that haven't yet been adequately addressed. And the research funded by NIH establishes that 50% of all mental disorders begin in the pediatric ages and 75% onset by age 24, and yet as of 2 years ago, only about 8% of the budget of the NIMH was dedicated to addressing the needs of children and adolescents. So let me ask you this: how does research of pediatric and adolescent mental health issues fit into the themes of opportunity you've identified within your first year?
Well, I agree with you. Those are critical issues because certainly the onset of a mental health problem in childhood or adolescence means that that individual, if not properly diagnosed and treated, is going to have a very long course. One of the things that I think we're trying to understand is what are the advantages of early diagnosis and intervention. I think there's a lot of need also just to understand in terms of basic neuroscience what is going on in the brain in bipolar disease, in schizophrenia, in major depression, in a number of the other conditions that do tend to come on in adolescence. The Human Connectome Project is an effort to try to do that in a more systematic way, putting together genetic variations with what the linkages are in the brain between various regions and how those neurological tracks are different in people who develop one of these diseases. But I hear what you're saying about the need to focus particularly on early onset risks. And here I think the National Institute for Child Health and Human Development, working with NIMH, which has been the main source of mental health research, and also with the Neurology Institute, NINDS, is undertaking, I think, a pretty important effort to try to develop a better understanding of normal brain development in young people, and then also to apply that to trying to see what happens in the course of the development of one of these diseases. Certainly the National Children's Study, when it gets fully up and going, will also have the chance to look for very early influences on mental illness in terms of environmental exposures, genetics, etc., because we've not really had a very good database, and that study, which will study now 100,000 individuals from preconception until age 21, should provide some other important clues.
Let me ask the indulgence of the chair. I have another question. Could I? One more question. Let me ask you about HIV and AIDS research, because I think that's really important. And 56,000 people every year living in the U.S. become newly infected with HIV. And in your opening statement, you mentioned the many ways that NIH research has contributed to the information that we know and the increased life expectancy for HIV-infected people. We had discussed previously an innovative program in the Bronx, in New York, where I'm from. Can you discuss that program and also the current state of HIV/AIDS research, specifically at the community level, that NIH is conducting?
So the program you're referring to is a innovative idea about testing and treating and then linking to care. Let me explain what this is and why it seems to be potentially very beneficial. You're right, 56,000 new cases each year, and that's been pretty flat for the past few years. We are clearly not successful in reducing the new cases of this epidemic, even though we've developed effective antiretroviral therapy and individuals who are HIV positive can now expect to live many decades. Still, we should be doing better in terms of ending the epidemic. The idea here is that most of the new cases of HIV, or many of them anyway, are actually acquired from individuals who do not know that they're HIV positive. Because at the present time, many individuals do not get diagnosed until they've already developed some symptoms. They're found to have their immune systems already compromised. At least by mathematical modeling and by some small studies done in other parts of the world, it looks as if you tested every one of us every year to see who is HIV positive. And as soon as somebody turned up positive, began treating them then, you would both improve their likelihood of a good outcome, but importantly, you would drop their viral load substantially so that their likelihood of passing the virus on would go way down. So the idea here is that you essentially reduce the viral load of the whole population by identifying infected individuals as early a time as you could. And mathematically, it looks as if that could actually end the epidemic without having come up with a vaccine, which has obviously been an enormously frustrating circumstance. To test that, this test and treat link to cure, or TLC effort, Link to Care, has been piloted just recently in the Bronx and here in Washington, D.C., with support from the National Institute of Allergy and Infectious Disease, so that we are going to be able to see, does this work, not in a mathematical model, but in the real world. And we kind of thought Washington, D.C. was the real world, and we thought the Bronx was too.
I do too. My two favorite places. Thank you very much. Yeah. Thank you, Madam Chair.
Dr. Collins, I'd like to ask you one question on behalf of Chairman Waxman, who had other obligations. He's concerned about the peer review process and also the Cures Acceleration Network. As you know, the NIH Reform Act of 2006 required that all research that the NIH conducts or supports has to go through a peer review process. And you pointed out in your testimony that the process is critical to ensuring that federal dollars are spent on the highest quality research. The healthcare reform legislation that the President recently signed into law established this Cures Acceleration Network, whose goal is to further research into treatments for certain kinds of conditions, specifically the ones we talked about earlier that have few existing therapies. The legislation established a competitive process for reviewing these canned proposals, but it didn't specifically require that grants go through the NIH peer review process. And so it's Chairman Waxman's understanding that the authors of the provision do not intend for the grant proposals to be subject to the process. What is your understanding of how canned grant proposals are going to be reviewed by the NIH?
We depend on peer review for everything we do, and the way in which we would expect this program to go forward would be to invite projects that seem ripe for investments of this sort, which is moving them through the so-called valley of death, where you have a promising compound, but you want to get it all the way to a clinical trial. Those would have to be peer reviewed to see where, in fact, are the most promising projects, the most promising opportunities. This is high risk, potentially high failure science. But we at NIH are very motivated to push this forward, and the Cures Acceleration Network would provide us with some flexibilities that we haven't really had before. But it would be done with peer review. One thing I want to say is that the bill does offer some DARPA flexibilities to NIH, so-called other transaction authorities, which we would welcome, in that once a project has been peer reviewed and initiated, it gives the project manager some flexibilities about how to move the project forward and to kill the project if it looks like it's failing and missing milestones. So we do embrace that kind of flexibility, but I want to assure Mr. Waxman that we would not imagine having projects get into this pipeline without that kind of rigorous peer review.
Thank you. Thank you very much.
Madam Chairman.
Mr. Shimkin.
Not that it just reminds me of the importance of having a hearing on the health care law. It's not a bill. It is the law, and so we need to deal with it. So I'm glad that Chairman Waxman thinks that there's some questions that need to be cleared up based upon the law. And also, you promised a great litany of things that we're doing, and dollars spent. My opening questions dealt with this driving research thing that you're doing, $250,000. You said you'd come back, give me some answers on that. I would hope you would, because then it's tough for us to defend the good when we have questionable dollars going in questionable directions that we need more clarification on. So thank you, Madam Chair.
Thank you. And just to reiterate, several of the members expressed to me during the votes that they will submit their questions in writing. So if we can get responses to all of these questions, it would be great.
We're happy to do that.
And I want to remind all of the members that they may submit additional questions for the record to be answered by the witness. The questions should be submitted to the clerk within 10 days, and then the clerk will notify all of the offices of the procedures. And I would like to just thank you, in particular, Dr. Collins. You have a very full plate. We're glad you gave us your afternoon. It was a wide range of questions. The members, I think, were impressed by the answers, and we look forward to working with you. And this meeting is adjourned. Thank you.
Great working with you.
You too. Thanks. Good.